All right. Thank you all for being here today for Mental Health in the Workplace. I am going to let Dr. Moser just give her a little introduction about herself, but she is a dynamic speaker who has a great influence and a great passion and wealth of knowledge in this topic. And I know you're going to really enjoy as well as learn some deep concepts today. So Dr. Moser, we will turn it over to you.
Thank you so much, Jean Marie. Welcome, everyone. Thank you for having me here today. I wish I could say that this topic is going to be super fun, but we'll do our best to make it fun. I do ask that this be interactive. I'm used to doing this in person where I get to like walk around the room and get feedback and have conversations. So I am hoping that we are able to have those conversations. So if you can and want to be a part of it, please take yourself off mute and be a part of that conversation. And or you can put something in the chat as well. I do have the chat in front of me and will do my best to look at it as well. But Jean Marie, please stop me if there's a question or a comment that comes up that we should and want to address. So that being said, let's get started. Okay, so mental health care is healthcare. So nowadays, there's a lot more in the news about mental health. Now, the question is, why is that? Is it because people are talking about it more? Is it because people have more issues than in the past? I'm not so sure about that, and I'm more than welcome to hear your feedback on that. You can always type it in the chat. But regardless of why we're hearing about it more, there's still a lot of stigma and there's still a lot of challenges out there for people. So mental health challenges are common, but oftentimes, and we'll actually talk about that percentage, oftentimes people do not seek care. So when we think about having a medical condition, for example, a heart condition, what would you, and put this in the chat, please, what would your guess be about the percentage of people who might not, that's not, seek treatment for something like a cardiac condition or diabetes? What would you estimate? Okay, so I have, so far this is all over the place. So I have one person that said about 55% would not seek treatment for a medical condition. Another person said less than 10%. And then somebody said as high as 95% would not seek. Anyone else want to add anything to that? 75%? Okay. Okay, so I do not believe that the numbers are that high for now 5%. Okay, would see. Okay. So so our numbers are all over the place. So my guess would be that for a medical condition, and I don't know those numbers, it would be less than 50% that would not seek treatment. The interesting thing about mental health is that that percentage is up around 60%. So it's much higher. Oh, somebody said would seek 95%. Oops, yes, yeah, you're absolutely right. So the majority of people who might be having a medical condition or, something such as that, as long as they have access to health care, the majority of them, we would hope, would seek treatment. When it comes to mental health, though, people don't seek treatment. It's well over that 50% mark. So why is that? Well, one of the reasons why is stigma. And we're going to talk more about stigma. Another reason is that professional help is not always easy to find. And part of the reason why that occurs is that the system is not always easy to navigate. So a lot of people don't know what do I do? What kind of provider do I seek out? What is it I need? So it can be very difficult for people sometimes to figure out where to start. And a lot of people are just not very well informed about mental health problems or care options. And oftentimes people don't know how to respond when people are facing mental health problems. So if anyone is familiar with like your ER or anything like that. Whenever we get into like a medical setting, even medical doctors don't feel comfortable dealing with mental health issues. Oftentimes, the medical doctors want to transfer that individual immediately to a mental health professional. So then let's start off with asking, what is a mental disorder? So a mental disorder is a diagnosable illness that impacts how we think, how we feel, how we behave, how we perform at work, how we carry on our daily activities, and our relationships. And if any of you have had a relationship or been in a relationship with someone with a serious mental illness or even serious depression, I'm sure that you realize how very difficult that can be. So let's look at some facts. 1 in 5 US adults experience mental illness each year, and this number is relatively stable. It's stayed that way for many, many years. 1 in 20 US adults do experience a serious mental illness. And when I mean serious, I mean these are the people that are coming in and out of our inpatient psychiatric settings. This next number, 1 in 6 US youth between the ages of 6 and 17 experience a mental disorder each year. That is concerning, of course. And 50% of all lifetime mental illness begins by the age of 14 and 75% by 24. So what I always tell people is when an individual has a psychotic disorder, for example, like schizophrenia, or even bipolar, or even serious depression, usually we see a first psychotic break sometime between the ages of 17 to 24, 25. So to assume that 50% of our lifetime illness would begin during those age timeframes for an individual would make complete sense. So, and it's not always easy to distinguish what's happening when we have somebody in those earlier teen, ages such as 16, 17, 18, because we don't know if they're experiencing their first psychotic break or if they are having a medical reaction to something or physical reaction to something, or they're withdrawing from something, or they've done some kind of a drug that may or may not show up in their drug screen. This next number is concerning to me, that suicide is the second leading cause of death among people aged 10 to 14. That's obviously very young. Maybe some of you have children in that age range, which is very concerning. And we already went over this, that only 41% of people with a mental illness do seek services. And again, we've said why. And part of that is this navigation. Navigation is just not always easy. So oftentimes people will ask, do I need medication or do I need therapy? Or does this person I'm trying to help need either of these? So the highest success rate for treatment is a combination of both. So that's medication management and therapy. So the next question is, who provides these services? So for medication management, although some primary care doctors will start someone on medication, we need to be a little conservative about that because people can have some serious reactions to psychotropic medications. For example, sometimes with an antidepressant, a person can have the opposite effect where they might even begin to have suicidal thoughts. So we need to monitor those. So we don't want those being prescribed by someone that's not going to be monitoring them. And I'm not saying that your primary care doctor wouldn't be monitoring them, but you certainly don't want to have someone in the ER giving you that. And then you don't have someone to check in with to see how it's working, if it's working, or if you're having any reaction to it. So other than the primary care doc, what I would highly recommend is that you seek a psychiatrist or a psychiatric nurse practitioner. So a psychiatrist is a medical doctor, could be a DO or an MD, who prescribes psychotropic medication specifically for psychiatric diagnoses. And a psychiatric nurse practitioner now is usually under the supervision of a psychiatrist, although the state of Florida is trying to change that. There's some legislation going around right now about that. So then the next question is, who does therapy? So psychologists, which is what I am, psychologists can do assessments. They can release people from the BayCare Act. They can do those types of things. And they can also do therapy. But in the community, you're mostly going to see your master's level providers who are going to be doing your therapy. So that would mean LCSWs, which are licensed clinical social workers, LMFTs, which are licensed marriage and family therapists, and your licensed mental health counselors, LMHTs. So those are the people that you're mostly going to see out in the community doing therapy. Now, another reason why people don't seek these services is because they're concerned for confidentiality. If I tell somebody something, will it get back to my employer? Will it get back to my coworkers? Will it get back to, family, whatever the concerns might be? So I always try to remind everyone that a licensed provider usually invests quite a bit in getting their license. So for, example, for me, I had quite a bit of student loans, I spent many years in school. So as a licensed provider, you are bound by the rules and the laws and ethics of your governing board. So for me, that's the Board of Psychology.
Dr. Moser, I have a quick
Yes,
question for you.
sure.
You're mentioning some of this stuff, some of these people are not in the state of Florida. Is all this true across all the states for the most part, or is there any differences that would occur because of being in a different state?
Very good question, Jean Marie. So when I say, quote, BayCare Act, what that means, because that name BayCare Act is different for every state. So what that is an involuntary evaluation. So a person is forced to be evaluated involuntarily. So they may not have a choice. They don't have a choice. That term is going to be different for every state, but it's an involuntary evaluation. And then that next step would be an involuntary treatment. And again, that's going to be different for every state. So I will thank you for pointing that out because I did not realize that. I will make sure I don't use that term BayCare Act, but instead it's an involuntary evaluation. So if a person is at risk for harm to themselves or others, or at risk for neglect, they can be forced to be evaluated. And in most states, they have a professional has 72 hours in order to perform that evaluation. And then they determine next step. Next step would be, does that person get discharged or released? Is that person being forced to go for treatment, or do they voluntarily go in for treatment? Does that help?
I think that's great. I just wanted to make sure because I know some things are different, like you said, but a lot of this there is some similarities. So we just want to make sure we're addressing everyone in our audience.
Thank you. I appreciate you telling me that. Yeah, so it's usually a similar process. It's just different terminology in the different states. But that getting back to the confidentiality though, usually in all states are pretty much the same. If you are a licensed provider, you're governed by your board, and your board requires you to maintain those confidentiality issues. So if you break that confidentiality, you are at risk of losing your license. Because when a person is licensed, they're not just licensed in their state, but they usually have to take a national exam as well. At least for psychologists, they do. And I do believe master's level do as well. So, you know, people take that seriously is what I'm saying. Like those providers that worked hard to get licensed take it seriously because they don't want to lose their license. And another reason why navigation is difficult is because of cost and insurance. So not everybody has insurance that covers mental health issues. And sometimes the copays are high. So that's another reason why people might not seek services. And please, if anybody has any questions, please jump in. Okay, I'm going to ask you to put in the chat, what do you think the #1 mental disorder in the United States is?
Oh, I saw many providers don't accept insurance, so I thought they were saying that was one of the biggest things. But we're seeing depression, anxiety, insurance, anxiety, depression. A lot of depression, a couple of anxieties.
Right. Well, and you're right. Many providers don't accept insurance. That's absolutely correct. Okay, so yes, most people do think that the number one disorder in the United States is depression. And I think the reason that most people believe that is because people talk more about depression. But the number one disorder is actually anxiety. So some of you did guess that. And I do believe that people hide anxiety a little bit better than others. And that is why people don't talk about anxiety, but they will talk about depression. For some reason, people feel more safe talking about depression. So, what is the difference between stress and anxiety? Um, so, stress is a physical or mental response to something that has happened to us. So, some kind of external cause. Maybe it's some changes at work, or maybe it's something going on in your home. So, there's something happening, there is a reason. Whereas anxiety is your body's internal reaction to some kind of stressor or stress. So, with anxiety, you're going to feel it's actually there's and we're going to look at this in a minute. There's actually it actually has a lot of physical symptoms and people don't realize that. So with stress, it usually is short term, or maybe it comes and goes over a longer period of time, but again, there's usually some kind of stressor. Whereas with anxiety, sometimes people can just have a persistent feeling that just doesn't go away. With stress, once that stressor is removed, often people feel better. And with anxiety, it can be constant, even if there isn't an immediate threat. So it's not like that fight or flight syndrome, but sometimes you can just have that general sense of anxiety. And for stress, not all stress is negative, some of it is positive. And there can be stress in buying a new house, even though that's exciting, there's still stress involved in it. But with anxiety, even though some anxiety can be helpful because it causes us to be aware of our surroundings and make sure that we're safe, it can interfere with how we live our lives. Anybody ever feel like this? You can put a thumbs up if you want, or um, you know, just yes, yes. I think we've all felt like this at times. But take a look at daily, yes. Take a look at this picture and look at how many physical symptoms we see here. Um, Sweating, shivering, trembling, heart palpitations, difficulty swallowing, breathing issues, dizziness, lightheadedness. So you can see, based on the number of physical symptoms here, how easy it is for people to mistake an anxiety attack with a heart attack. So it's not uncommon for a person who doesn't have a history or an understanding of what a panic attack feels like to show up in the ER thinking that they are having a heart attack. So I'm going to ask this question. Has anybody out there never experienced anxiety? Never experienced anxiety. So if you don't want to put it in the chat, you can put a thumbs up. But has anyone never ever had any anxiety ever in their life? Okay. So, yes, most of us have, everyone has experienced anxiety at some level, driving a car, having kids, these are all kinds of things that create anxiety for us when our kids start to drive, right? They all creates anxiety. But the anxiety that we might be experienced as quote regular anxiety is not the same as an anxiety disorder. An anxiety disorder differs from normal stress and anxiety because it lasts longer, it's more severe, and again, it interferes with how we think, how we feel, how we behave, and how we function. This next number, I believe, is probably not accurate anymore, but the median age of onset is 11 years old. But think about it, 11 years old, people, young kids experience anxiety. My guess is that this number is actually lower, that children as young as 6, 7, and 8 are experiencing anxiety. I have had teachers tell me that they have seen 5 and 6-year-olds with anxiety. So, and I do believe that COVID probably fed into that. I'm not one that wants to blame COVID for everything, but COVID did create anxiety for people. And we can talk about that if anybody's interested. Otherwise, we'll just move on. Does anybody have any questions about anxiety before we move on to depression?
You can type that into the chat, or if you want to take yourself unmuted, you just hover over your name on the side or your mic up on the top and you can unclick your mic.
Okay, doesn't look like anybody has any questions, so let's move on to depression. All right, so a major depressive disorder, which is your most common depressive disorder, it lasts for at least 2 weeks. So what that means is that a person must experience the symptoms for a minimum of a 2-week period. So when most people struggle with depression, they don't necessarily feel depression every minute of the day, every day of the week, 365 days a year. What happens is people have episodes. So they may have a few weeks where they do feel depressed and then they feel better. And then they might feel depressed again. So a person tends to move in and out of it. And as an individual learns coping skills for their depression, then they move out of those episodes quicker and stay out longer. Or if they're on an antidepressant or some kind of medication that helps them with it. So in order to be diagnosed with a major depressive disorder, though, those symptoms will last a minimum of 2 weeks at one time. And again, just like anxiety, depression affects how we think, how we feel, how we behave, how we physically feel, not just emotionally, and how our relationships are. And sometimes some people with severe depression have a hard time even getting out of bed or taking showers. If anybody here has had a relationship with someone, that could be a romantic relationship, a family relationship, or a friendship with someone with clinical depression, can you put your thumb up? You can do like the quick thumbs up if you don't want to stay, on in the reaction. Okay, so we have had some. So when we think about having a relationship with someone with clinical depression, what does that feel like to you? Amy, do you have a question?
No, sorry.
No worries, no worries. So if you've ever had a relationship with someone with depression, it feels hard. Okay, I see some thumbs up. Yeah. It's difficult. It's exhausting. Perfect explanation. It's exhausting. And the reason being that an individual who's struggling with depression often cannot see out of their blinders. So they have a hard time seeing outside of their internal struggle. Yes, helplessness, Christy, is absolutely 100% right. As a person who's cares about an individual who struggles with clinical depression, we have a constant feeling of helplessness because it's very hard to get that person out of that. And so that's why they need to seek professional help. All right, so now we're going to talk about some complications. And this is another reason why treating depression can be difficult. When it comes to medication, so let's talk about blood pressure for a minute, okay? When a person has struggles with blood pressure, they often get put on a medication, maybe a Atenolol. I'm not familiar with all the blood pressure medications, but they maybe get put on a blood pressure medication, and it generally works within a short amount of time, or it doesn't work, and then they try something else. But you know fairly quickly whether it's working or not working. Excuse me. With psychotropic medications, that can be different. Okay, with psychotropic medications, depending on the type of medication, it can take 4 to 6 weeks, even sometimes 8 weeks for it to work. So let's take an example. So for an antidepressant, and nowadays, anxiety and depression are often treated with antidepressants. The only type of medications out there other than Buspar that works for anxiety are as needed, and they only work for a short period of time, and they're very addictive. So for example, Xanax or Ativan, those are your medications that you'll hear people talk about taking. They only work for a few hours, and they're highly addictive. So a lot of doctors, and they're in a class called benzodiazepines, and a lot of doctors will not even prescribe them because they're concerned about the addictive aspect of it. Buspar is a medication that you have to get in your system like an antidepressant. I have not heard from a lot of people that Buspar is very effective. I know that doctors do try to put people on that first, but it doesn't often do a lot from what I hear. I'm trying to think of some other, there are some like not anti-anxiety medications, but they're like medications that are for other issues that people will try first, like hydroxyline or gabapentin sometimes they use. So there are some non-psychiatric medications that they will try to help people to see if they'll work first. But again, they may or may not work. So an antihistamine or something like that. But when we talk about antidepressants, we have a wide range of antidepressants out there. There are some that are longer acting, that take longer to get in your system, and some that are faster. So let's look at the range of that. So for example, almost everyone's heard of Prozac, right? Prozac was the very first antidepressant that was on the market. Prozac doesn't have a ton of side effects, but it can take a good 8 weeks before we know if Prozac is working. It also has a huge range of dosing. So most doctors will start, most psychiatrists or psychiatric nurse practitioners will start someone on a low dose of it and then slowly increase it. So it can be a good 3 months before we know if that medication is working. So let's say you now have spent 2 months. We'll go with the shorter end of it. You've now spent 2 months trying to see if this medication works for you or for someone that you're helping, and you find out it's not. So instead of being able to take you right off that medication, the doctor has to titrate you off of it. So they have to slowly wean you off the medication before they can put you on a different one. So when we look at the other side of the other side is like a medication like Lexapro, for example. Lexapro, it does start to show some benefit within 2 to 4 weeks from what people have said. It's not as large a range of dosing, but it can have additional side effects. So everybody's chemistry is different. So not what works on one person may not work on the next. So that's what makes medication so difficult. And then you have those cases where maybe nothing is working. But while you've tried them all, you could be 6 months into it before you even realize that. And then your doctors have to get creative. Another complication is psychosis. With severe depression, an individual can have some hallucinations and delusions. So we're going to look briefly at some of the signs and symptoms. We've talked about some of these already. We've seen some of them with anxiety because there are some crossover of similar symptoms. But what I really want to point out here is that the range of symptoms is physical, emotional, and cognitive. It's how our brain thinks and works, right? So when we were talking about depression earlier, with an individual who's struggling with depression, oftentimes their thinking is very negative and very narrow. And so it's very hard for them to see outside of that. Does anybody have any questions or comments on depression before we move on to substance use?
And I also dropped my email address in. If anyone doesn't want to ask a question out loud, but they'd like to have someone kind of ask it for them, I will be watching my emails. It is up in the chat of my name, jeanmarie.scordino@baycare.org, because we know these are tricky issues going on, but they are stuff that all of us deal with. I could probably guarantee that each one of us on this call, if we're not dealing it with ourselves, have come across someone who's had to deal with these. So this is great information to have, and we just want to give you that chance to ask any questions you need.
Okay, well, feel free if you do have questions as we move along to either put them in the chat, send them to Jean Marie, or unmute yourself. I do also want to say, I know you're all off camera, so if you need to get up and move around, please do that. We are going to at some point have Jean Marie lead us in an exercise to do that, because some of this stuff does get kind of heavy. Now we're going to move into substance use. Okay, so approximately 8% of the population 12 and over have a substance use disorder in any given year. So maybe you're saying to yourself, 12, wow, that seems young, doesn't it? But I will tell you that I had my late in life twins. So I have teenage twins. When they were 13, one of them was talking with, I don't know, a friend or someone. I can't, everyone accuses me of eavesdropping here, but I certainly wasn't. But anyway, I overheard her talking about a friend of hers who I knew who was drinking alcohol, 13 years old. So don't ever tell your psychologist mom that, right? So I stop her and say, hey, let's talk about this for a minute. What do you mean so-and-so is drinking alcohol? What's going on here? And to this day, I remember the response because it really struck a chord. She says, well, mom, she's experiencing anxiety and her mom's not helping her with it. So I went, wow, who taught her that alcohol was going to help her with her anxiety? I did not get an answer to that. But when I think through that, I think, well, social media, parents, other friends, I'm not really sure, but it is certainly concerning to me that children as young as 12 and 13 are getting the message that alcohol and or drugs can help with their mental health or their anxiety or depression. So the use of drugs or alcohol, though, does not mean that a person has a substance use problem. And we're going to talk about what does it mean to have a substance use problem. We're not there right now, but we will talk about that. So 75% of people who do develop a substance use problem do so by the age of 27. So if you think about the lifespan of an individual, right, most people do live to be in their 70s, 80s, not even 90s nowadays. So if you have or struggle with a substance use problem starting at the age of 27, then you're going to be in recovery or struggling with that for, more than half, way more than half your life, right? Way more. So that's a pretty tough life to live. And then finally, alcohol use disorders are almost 3 times as common as drug use disorders. Well, why is that? I'm sure most of you know or can guess why that might be. So alcohol is more readily available. It's more socially acceptable. It is legal at certain ages, right? So people do tend to go toward alcohol. It's not uncommon too for people to just hand people a drink or encourage them to drink. Okay, so let's look at some co-occurrences. So a substance use disorder can co-occur with any mental health issue. Now, so people will ask the question of which comes first? Well, we don't know that because for every individual that can be different. So an individual might start using alcohol or drugs, and then that in itself can cause a mental health issue. For example, long-term use of alcohol and long-term use of marijuana or cannabis can actually cause a person to have anxiety. And then also keep in mind that alcohol is a depressant, so it can cause depression as well. But some people also start to have some mental health issues and they're not sure what's happening, so they start self-medicating to deal with those issues. That's what we just said. And people with a mood or anxiety disorder are 2 to 3 times more likely to have a substance use disorder. And again, we don't exactly know why or which comes first. We just know that that's the case. Now, when we look at common substances, I won't go through all of these, but what I will do is point out one up there that's of concern, especially more recently, and that is spice. So spice is a synthetic marijuana. Yes, it is acceptable. I see somebody put acceptable for accessible, I mean for alcohol. So getting back to spice, spice is cheap. It's easy to get. They used to sell it at like 7-Elevens and places like that. I'm not sure if they still do that. It is a synthetic marijuana. It's man-made. And in most urine drug screens, it doesn't show up. So if someone goes into a hospital and they're experiencing some psychosis, hallucinations, or delusions, and you do a urine drug screen on them and it shows up clear, we're going to assume they have a psychotic disorder, maybe a first psychotic break, rather than it being a substance, unless they tell us. Spice can cause someone to be psychotic. It can also trigger a psychotic disorder. So it is a dangerous drug. And again, we don't often know when a person is taking it. The only other one I will make a comment about up there is bath salts. It's a synthetic stimulant, and a lot of people think it's the bath salts that you actually put in your bath, and it is not. It just looks like it. Now, we do know that opioid deaths are on an increase right now. Opioids are your pain medications. Fentanyl is extremely dangerous. That's not a pain medication, but it is out there on the street. And a lot of times recently, they are lacing cannabis with fentanyl, and it can actually be life-threatening. Adderall, yes, Adderall is an amphetamine. A lot of people seek Adderall from their doctors, claiming that they have a concentration or focusing issue, ADD or ADHD, when they really don't. And kids are also learning that if they take Adderall, it will help them do better on tests. So it can be very abused. And at high dosages, it can also cause someone to have some psychosis as well. Okay, so what are some warning signs that someone might be using? So basically what we're going to do is look at the symptoms that we would use to diagnose a substance use disorder. So of course, increased substance use over time. So an individual starts increasing their use. So maybe you have a friend, you would go out, maybe you'd have a glass of wine with them, and then you notice as time goes on, they're drinking 2 or 3 glasses, or maybe they move into harder liquor and they're drinking more and more. And then you also find that they're developing a tolerance to whatever it is. So maybe it used to be that after 1 glass of wine, they felt a little tipsy, so they knew to stop. Now it takes 4 or 5. And so they keep drinking. So they're developing a tolerance. The impact of the alcohol or the drug is not happening unless they take higher dosing of it, higher amounts. Difficulty controlling use. So For example, I'm only going to have one drink, but instead they have 5 or 6, and this happens repeatedly. And then if an individual stops using a drug or alcohol, they can have symptoms of withdrawal. Alcohol withdrawal is absolutely horrible and can be very dangerous. A person can have all kinds of symptoms, and if it's not handled appropriately, it can be life-threatening. Preoccupation with the substance. This is when a person is talking about it almost all the time. Maybe they stop attending family gatherings or social gatherings so that they can use. And these are all indications that a person is moving into a substance use disorder. And of course, one of the biggest ones is continued use even after recognizing that there is a problem. So why do people not access care? So, okay, so we're going to move out of substance use right now. So before we move on to stigma and all that, does anybody have any questions on substance use or anything that they would like to share? Okay, everyone doing okay? You need a break or anything? All right, then let's keep going here. So what are some barriers to accessing care? Of course, we spoke earlier about the stigma, and we also spoke about navigation. So regardless of how far we've come with mental health care, there's still quite a bit of stigma out there, especially in the workplace setting. In the workplace, people are viewed as not being as competent. They're viewed as not being as reliable. So a lot of people are worried about even letting people know that maybe they're struggling with something. There's also not always a lot of awareness, and it does depend on the culture of the organization, whether people are aware of mental health issues and how that is handled in the workplace. There's a lot of fear. Could somebody become aggressive? There's all kinds of different, maybe there's fear that if I go for treatment, there'll be some kind of repercussion, or maybe I'll have a reaction to the medication. So there's fear can be, can take a different picture for a lot of different people. And then of course, we talked earlier about the issues of confidentiality, especially in the workplace. People are concerned about being perceived differently in the workplace. Now, I will give you an example when we talk about leadership of that type of situation. So let's talk about mental health in the workplace. So what are some signs that a team member may be experiencing mental illness? So or a mental health challenge. I'm going to say one thing. If this is the only thing that you remember in leadership, remember that if you notice a change in an individual on your team or in the workplace, that is a sure indicator that you might want to be looking further or checking out or even touching base with them. So for example, if you have an employee who comes into the office every day and they're well dressed and they're alive and awake and, all that, and they have a lot of their usual bubbly, energetic self. And then you notice that they're coming in late, that they look disheveled, that they seem tired. That is a sure indication that something is going on. So that change in physical functioning and or appearance is the most important factor to notice if you are concerned about someone who might be having some challenges. There also might be some changes in a person's thinking. So you might notice that they are they're making statements that aren't making sense, or they're staring into space. Someone did make a comment that we are virtual, which does make it harder to identify. And you're absolutely right that people do hide behind that screen by texting and talking. But I still think it's important that I assume you all have teams like this, that you get your team on camera once in a while just to be looking at them and watching them. Or you may notice their work productivity changes. those types of things. So we can start looking at other areas as well if we can't see them. But I would highly recommend that you try to put eyes on them at least once a month, if not more. But you also, again, you might notice changes in their thinking processes. Maybe they're not, maybe they're making more mistakes. Maybe they don't seem to remember things that you tell them, or they're not socializing as much, even on a virtual platform. So you're not able to get interactions from them. And like Jean Marie just said, you might notice a change in the tone of their text messages or their emails, or maybe they're not responding to emails or text messages. And then you may even notice some inappropriate behavior. Maybe they have some anger outbursts that they're not usually, that you don't usually see in that individual, or more irritability. These are all signs. And then, of course, one clear sign is more frequent absences from work and reduced engagement in their work. So maybe they're just not as excited about it. Maybe they're not taking the initiative that they usually take. So these are some ways that we can watch over our employees and our team members. So what should you do if you're concerned that maybe something is happening? I would definitely make sure that you've done what you can to check it out. Maybe observe, make sure you're observing their behaviors, maybe please note specific behaviors, and then encourage communication. So the first words that I often say to somebody when I feel like there might be an issue is, I am concerned. And then when you say that you're concerned, it's important that you say why. When I say why, I mean specific behaviors that you are seeing. So, for example, you might say to somebody, I am concerned. I've noticed that you've been missing work a lot lately, and that is not something that you used to do, that you usually do. Is there something that I can help you with, or something that you would like to talk about? And then create a safe space for that person. And maybe they don't want to talk to you, but they indicate that there's something going on. So then you refer them to your EAP program. And then maybe they need some adjustments. Maybe there's something going on that they, maybe they have a sick child or something like that. And they might share that with you. So reasonable accommodation, obviously. Sometimes there are some positions that you cannot do that with. So the most important thing is to keep in mind is that the leaders are the emotional regulators of the organization. So you all are the people that they're looking to set the tone and to set the culture of the organization. And I'm going to give you that example I had said. So I don't know, 2-3 years ago, I was invited to be on a panel of mental health experts to speak with a large group of human resource professionals. And of the 4 of us that were up there, I believe there was 4, 3 of us worked in the mental health field, and 1 was an HR executive, human resource executive. So this HR executive shared with the group that she had struggled with a significant mental health issue and had actually been hospitalized. And that was a hard thing for her to tell people. I mean, this was a group of, quite a few people. They were HR individuals. These were her peers. And she told them what had happened and that she had been hospitalized. And she told her story. Believe it or not, that group of individuals, when that panel was over, did not want to speak to the other 3 of us who were, quote, experts in the field. They only wanted to speak to her because they connected with her sharing her story. Now, I'm not saying that you want to go around telling all your personal information. What I'm saying is that it's okay to acknowledge that people do have struggles with mental health issues at times in their lives. So what are some things that we can do about this? So some things that we can do. We can incorporate mental health awareness trainings into professional development programs. I assume that's what this is for you all as well. But incorporating it into your regular training programs that you offer the majority of your team members or your employees, and promoting that awareness and acceptance from the top down. So you all, again, are the emotional regulators. So if you do not share at all with people that it's okay to struggle once in a while, then they will believe it's not okay. So being aware that you are setting the tone for that. And again, I'm not saying you want it to be this constant talk about personal issues that can interfere with work. I'm just saying that it's okay to acknowledge that people do struggle with mental health issues at times in their lives. Also, authentic communication is the term I'm going to use here. Being authentic with your people, and when you're authentic, you can at times share that, hey, that was really tough. I'll give you an example, and this is a pretty tough example, but I want to be transparent here. We did have a recent death by suicide of one of our leaders, and it was very difficult for our team to acknowledge and to accept. And it was a hard loss for a lot of people. And it was a hard loss for me as well. So I was able to share that with the team and the people that I spoke with and say, talk about the struggles that I had with it as well, which opened the door for them to talk about it too. And talking about it is really what helps people work through it. Um, Again, making mental health discussions and activities a regular occurrence. So maybe having a virtual social gathering. Some people have sent out like a lunch voucher or something so people can buy lunch, and then maybe having some kind of a activity that you do during lunch or lunch and learn. Communicating visually and verbally, just making sure that you have some clear communication, that people are seeing that, including mental health in your wellness plans. We're coming up on Mental Health Awareness Month soon. Maybe using that as a way to open up that door to include that in some kind of a wellness plan. And then, of course, it's important to foster a relationship with your EAP provider, your employee assistance provider. All right, so let's talk about mental health. So what are 5 ways that managers can talk about mental health without overstepping? And that's the question that people ask, without overstepping. So I think it's important to acknowledge that these discussions might be awkward. I don't think it's easy to address some of these issues. And if you're noticing that there is some change in someone, it's not easy to say, well, I've noticed that you're not really focusing on your work, or you seem distracted all the time, or you seem withdrawn. Even though it sounds like it's an easy discussion to have, it's often not. We don't want to single someone out, especially in a group. If we want to talk to them, we want to pull them aside and speak to them individually. We do not want to point it out in a group and make them uncomfortable. It's often important to let people know that they don't have to share, that it is a safe place, but if they would like to share, that you're there for them and that you would like them to be able to do that, but you're not forcing it. Know when it's important to bring it up. It's not always the appropriate time to bring something up. So gauge that, gauge what is a good time to bring it up. And finally, recognize that that you may not be the best resource. So if somebody brings up some personal issue that they're struggling with, it's probably not in your area of expertise. So it's time to refer them. And you all know what your EAP provides to you. So maybe it's time to refer them to that. Maybe there's somebody that you know of that's a good resource in your organization. So it might be important to refer them to that person, because maybe this is not within your wheelhouse. Does anybody have any questions up to now? Now I just threw out a lot of information. Mhm. Somebody put in the chat, if anybody needs to talk about anxiety or panic disorder, I'm your girl. Any questions? Okay. Well, if there are no questions, we are going to be moving into a pretty tough topic next. We are going to be talking about suicide detection and prevention. And I will, when we get to that, well, I'm going to say it now. There might be some of you out there that have had family members or close friends die by suicide, maybe attempt suicide. This may not be an easy topic for you. I want you to know that if you do not feel that you can handle it, please take a break. We are going to have a short movement snack that's going to be led by Jean Marie before we get into this discussion. So if anybody feels that this will be a difficult discussion for them, please let Jean Marie or your supervisor know, so that we certainly understand that. I am going to try not to make this too deep, but if anybody does feel comfortable sharing, you're welcome to do that as well. So Jean Marie, let's take it away and give everyone a nice break here.
Thank you. I think one of the things you mentioned earlier was how when we have anxiety, when we have stress, and when we are listening to stressful topics, sometimes it creates a physical reaction also. So I'm going to take you through just a couple of things to kind of help to de-escalate the situation. One is to get the body to move better. And when we move more, we create circulation of our system, which helps to move oxygen and nutrients through the body. And when we're moving that oxygen and nutrients through the body, we're clearing out a lot of those stress hormones. So there is a lot of research out there that shows that by doing what I love to call movement snacks, we can help to de-escalate some of the emotional stress that we have on our lives and give us yet another strategy to deal with some of the stresses and anxieties that come at us. And one of the biggest areas that gets stressed out is in our thoracic spine. We tend to sit at computers. We tend to lean forward. We tend to, when we're feeling not good, we kind of draw in. So if I can create a little movement in that thoracic spine, I can have a much better feeling. And I am going to get rid of the background to just a blur, so maybe you don't lose me so much. Okay, so what I'd like you to do is if you'll all stand up for a moment. If for some reason you cannot stand, if you just scooch to the front edge of your chair. And I'm going to ask you to take your right hand and just rotate it across your body. You're going to keep your eyes forward as if you're looking at the screen and just kind of rotate. And you should feel your hips moving and your chest moving. And usually when I do this in a group, I make them do sound effects because it makes them giggle. So it's like whoosh, 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 whoosh. All right, now hang out over here. Now we're going to take the left hand above your head and you're just going to wave over the top of your head. And as you do that, your hips are sliding side to side. So we're going whoosh, whoosh, whoosh. Nice. Now we're going to take both hands and see if you can move them together. Again, in a group, I love this because it's entertaining to me to see sometimes how people move, but we're going to rotate and reach over and come back, rotate and reach over and come back. You should feel your hips turning. If you're sitting in the chair, you should feel the hips swiveling on the chair and just kind of rotating and retracting. Now we have to do this all with the other side. We're just going to come across and back. This loosens things up. It gets all that blood going to the brain, makes us more creative and accurate in what we're doing. We'll just hang out over here, take the hand above the head and that whoosh, whoosh, from side to side. And then we'll rotate both together. Awesome. So that should have felt good and got things moving along. My second favorite thing to teach people, and I always preface this with, I am not a licensed mental health clinician, but I am going to give you my number one favorite de-stressing activity, and it is breathing. Too many times we tend to breathe up in our chest and we're letting our shoulders come up and down. So I'm going to ask you all to go ahead and sit down in your chair, or you can stand up nice and tall, feet flat on the floor, and just relax. And I'm going to ask you to take a deep breath in through your nose because that's how we filter the air. And then exhale. Did you feel your shoulders rise and fall as you took that breath, or did you feel your body expand like a balloon? We want to make sure that when we're breathing, we're actually breathing deeper into our diaphragm. If you put your hands down here at the bottom where that rib cage is, it's almost like you're pulling that rib cage open. And what that does is it brings that oxygen deeper down into our lungs. But that physical part of it is I'm no longer using my neck and my shoulder muscles to do that work. And when we breathe through our shoulders all the time, we tend to have more stress. We tend to kind of be in this position all the time. And that affects our mood if we're always here. So we're going to just do 4 mindful breaths. And when I do these 4 mindful breaths, it kind of de-escalates the situation. It pumps my body full of oxygen and nutrients, and it helps to clear out some of those stress hormones. And if I happen to be in one of those anxious moments where my amygdala wants to have me fight or flight something, it gives me a pause in order to kind of allow my body to go, what's really going on here? And allows me to just to kind of focus in and take care of me. So now we're going to do those 4 mindful breaths. Think about your hands on the bottom of your ribs and your ribs coming out as you take that deep breath in. And then exhale. Inhale in through the nose. Feel that oxygen filling up your lungs and your body expanding. Exhale, push all of that negative energy out. Get rid of the carbon dioxide. Inhale in. Exhale, feel your body relax and focus. Last one in for 4, 3, 2, 1. And exhale, 4, 3, 2, 1. So just as a little commercial in the middle here, make sure you're taking time to take care of yourself. Stress and anxiety hits all of us in life. Something's always occurring. Figure out what strategies you have that you can do for yourself. Make sure you tap into the resources that you need, but always take that moment and say, it's not selfish to take care of myself, because it's not just me, me, me. It's just me too, not just me first. So make sure you're putting yourself in the mix as you're taking care of everybody else. All right, hopefully you all feel all good and just kind of a little relaxed and ready to move on with our topics.
Thank you so much for that, Jean Marie. Yeah, I think self-care is very important. You know, when you are on an airplane, they always tell you when they're going through their little spiel in the beginning, the flight attendant, that you need to put your oxygen mask on first in case of an emergency. And the reason they tell you that is because if you don't and you pass out, you won't be able to help the people that you need to help. So it's important that you take care of yourself, or you won't be able to be there for anyone else. I do see in the chat that there are some resources that your organization provides to you, some wonderful resources. So please look that over and reach out for any of those resources. So our next topic is a deep one. Again, like I said, we are talking about suicide detection and prevention. Again, it is probably not within your wheelhouse of expertise, so we're going to talk about some resources for you here as well, and some things that you might notice. I do want to start off by saying, again, this conversation can be very difficult for people, and if it is difficult for you and you feel you need to take a break, please do so. It is important that you take care of yourself. And also that it is not your responsibility to keep everyone safe. We just want to try to do that. So I'm going to start off by saying when an individual attempts suicide, they don't do it for one reason. They don't do it because of anything you've said or not said to them, or anybody else has said or not said to them. They do it for multiple reasons. So when we get to that, we'll talk a little bit more about that. So we're going to start off by just looking at some data here. Now, this is just in Florida, and I apologize for that. I would have put the national data on here had I realized it, but just to give you an idea of a state and the data out there, that in the state of Florida, suicide is the 14th leading cause of death. And just so you know, in comparison, Florida is ranked one of the worst states when it comes to mental health resources. I want to say we are ranked something around 48 or 49. So that number has actually improved suicide used to be the 8th leading cause of death. But these trends are probably common in other states as well. My one concern is that age group between the age of 25 and 34, there is a higher risk for suicide attempts at that age group. So keep your eye out for that as well. Oh, there is some, I'm just looking, there is a little bit of national data there. If you look at the very bottom, nationally, you can see the number of deaths by suicide, and this is from 2020, was over 45,000, almost 46,000 there, and then you can see that rate as well. So let's talk about some definitions. So when a person is having suicidal ideation, I'm sure you've heard this term before, this means that an individual is having thoughts. So they're having thoughts of suicide. That does not mean that they have plan or intent to follow through on it. It just means that they are struggling with thoughts. When an individual engages in suicide gestures, what they are doing is harming themselves without the intent to die. So that may show as cutting. It may, an individual may engage in headbanging or hitting themselves, those types of things. Oftentimes, when a person is engaging in suicidal gestures, what they're trying to do is get their focus off of their emotional struggle and make it more tangible or more physical. A suicide attempt is self-harm with the intent to die. So that is, if that helps with understanding the difference in these terms, hopefully. So why do people complete suicide? Okay, so people complete suicide, again, never for one reason. Okay, so a sense of unbearable emotional pain would be the reason why a person would go down that path. So what that might mean is a person might be struggling with many different issues that they do not feel that they can see a way out of. It could include physical pain as well, so I don't want to discount that. They might be experiencing intense frustration. They might be highly disappointed. And this word hopelessness is key here. Overwhelmingly desperate feeling of hopelessness. So I used to do actually assessments for individuals who were being evaluated for their risk for suicide. And that hopelessness was one of my key indicators. So if I would say to a person, do you feel like you have hope for the future? And if they would say no to me, then that would be that would mean I would need to go down a more specific path because I was highly concerned at that point. An individual who is thinking about suicide does not see a lot of options for their life getting better. And they believe that that decision to end it is the only way that they can end the pain that they're experiencing. An individual might be experiencing severe depression and again feels no way out of it. It can also be an impulsive act. So the percentage of individuals who do complete suicide while under the influence is somewhere between 25 and 30%. So when an individual is impaired, they have a higher chance of attempting suicide. So we need to be concerned about that. There are some people who do struggle with hearing voices that tell them to harm themselves, and they can even tell them to harm other people. That would be your psychosis. And finally, some people do complete suicide without the intention of completing it. So it could be a mistake. And I'll give you an example. When I used to do these evaluations in the ER of one of our big hospitals, I had an individual who I knew very well. She was a cutter. She had a serious history of trauma, and she would cut on herself a lot, but her intention was not to end her life. Her intention was to help herself through that emotional pain. And oftentimes she would come in, that we would fix her up, and I would release her. But I noticed that each time she was coming in, her cuts were getting deeper and deeper. And so my concern was increasing. So finally, the last time that I saw her, I said to her, I am not going to let you go home today. I'm going to send you for treatment. And she was upset with me because we had that kind of a relationship. And she said, why? You know, I'm not trying to harm myself. And my response to her was, I know you're not trying to end your life, but your cuts are getting deeper and deeper. And my concern is that you are going to accidentally end your life. So therefore, we need to find some better ways for you to cope rather than cutting on yourself. And this had been a lifelong pattern for her. So that was not an easy feat. So that gives you an idea of why some people would get to that point of thinking that suicide is the answer. So how do you talk to a person who might be reporting that they are struggling with suicidal thoughts? That is not an easy discussion to have. And so when you ask, or if you feel you need to ask a person that question, I always encourage you not to ask the question with dread, because we don't want to be afraid of the answer, even though it is a very scary place to be as an individual asking that question. I think the first way you start is, again, by letting them know you are concerned. So it's very similar to having that conversation about substance use that we talked about earlier, that just coming out with, I am concerned, and this might be why. Please do not express a negative judgment. Maybe those of you out there who have had close friends or family members die by suicide, you might recognize the many emotions that go along with that, and one of them being anger. So be careful of showing that to somebody that you are concerned about. I'm not saying that that anger isn't valid, and I want to encourage you to be able to explore that in a safe place. Just when we are talking with someone that we are concerned about their safety, we do not want to show that we are in any way negatively judging it. This is a case where we want to fake it and appear confident because we want to reassure this person that there is a light at the end of the tunnel and we are going to help them get the resources to get there. So asking that, so discussing your observations with that person is important. So if you do have concern about someone, then there's a reason. There's something that you've seen or maybe heard. Maybe you've heard them make statements. There are people who will make what I call passive thoughts of death, and they might say, I wish I wouldn't wake up tomorrow, or I wish I wasn't in this life anymore, but they have no intention of hurting themselves. So maybe a person's making those kinds of statements, or maybe they're making more active statements, or maybe they're doing some things that bring you some concern. And we will talk about those behaviors as well. There are two risk factors that put somebody in a category of being more concerned for their safety, and that is if they are using drugs or alcohol, as we discussed earlier. The chance of a person attempting to harm themselves while they're under the influence is higher than if they are not under the influence. And then another risk factor would be a person who's made that attempt in the past. So if an individual has attempted to harm themselves in the past, there's a higher chance they might try again. And I'm going to throw out another risk factor out there, and that is a person who has lost a family member or a close friend to suicide as well. So what do you do if you think somebody might be struggling with suicidal thoughts or suicidal actions? You want to take that threat seriously, answer their cries for help. The majority of people will cry out for help. I'm not saying that everyone does that, but some people do cry out for help. And we want to be able to answer that if we can. And we want to ask the direct questions. And finally, guide them to professional help. You are not the ones that need to be there to help them through this, but you can help connect them with the resources that might be able to help them. So what are some of the questions that we want to ask? Are you having thoughts of wanting to end your life or hurt yourself? So The way I word that question is, are you having thoughts of harm to yourself or anyone else? And if a person says yes, then I go down another path of asking questions. Do you wish you were dead? Some people, again, like I said earlier, have passive thoughts of death, but they have no intention of hurting themselves. So that's why I look at those three areas when I'm assessing someone. Again, you're not a professional. I'm not expected to know how to go down that path, but I always look at, do you have the thoughts? Do you have a plan? And do you have intent to harm yourself? So that next question is, if you were going to hurt yourself, how would you do it? Because that plan can determine whether a person has access or means. So if, for example, a person says, I would use a gun, and they do have access to a gun, then there's a much higher concern. And I would encourage you to take the steps to ask them to turn that gun over to someone, or make sure they don't have access to it. If a person tells you that they would overdose on medication and all their medication is locked up, then they don't really have easy access to their means. But if there is Tylenol or Advil in the house, they could potentially overdose on that. So we do want to be careful about that as well. And sometimes people who do want to harm themselves do choose a date and say, this is when I'm going to do it. So I would ask that question as well. And then we already went over that, the means. So what are some warning signs? So some warning signs, and this is, I had mentioned that we would talk about this. An individual does talk about wanting to die. They might be struggling with a lot of guilt and shame. They might feel like they are a burden for others. It is not uncommon when working with the elderly or having an older population, maybe parents or grandparents or anything like that, for them to make statements about being a burden to others, although usually in those cases they are not trying to harm themselves. They're just worried about being that burden. What are some feelings that they might experience? They might report feeling empty or hopeless, trapped, or having no reason to live. They might be extremely sad, maybe more anxious or agitated, or having struggling with a lot of rage. This one is important, this unbearable emotional or physical pain. And you might notice some changing behaviors, such as making a plan or researching ways to die. If you ever come up upon someone who's on the computer researching ways to die without pain, that is of concern. So you want to intervene there. Withdrawing from friends, saying goodbye, giving away important items. Those are all indicators. Making a will, not necessarily, even though if you see these other indicators and that is on there as well, then that increases your concern. But people do make wills at all different ages and stages of their lives. You might notice that an individual starts taking more dangerous risks, such as driving their car too fast or displaying extreme mood swings, or eating or sleeping more or less, or again, increasing drug or alcohol use. And that does put them in that higher risk category. So what happens if you notice that someone might be showing these types of signs? So there is a national crisis line called 988. I don't know how many of you have heard of that before. This has been a wonderful addition to the crisis lines that are available to people who are struggling with severe depression or anxiety or suicidal thoughts. The 988 Suicide and Crisis Lifeline, literally all you have to do is pick up the phone. It can be your cell phone, landline, whatever, and hit 988. So if you are concerned about someone, I recommend taking their phone and dialing it for them and putting them on the phone. And I will explain what happens when you call that number. They can also, some people do feel safer texting. They can text as well, or they can chat. If anybody would like to take a picture of this, please feel free to do that. I'll give you a few seconds. Okay, so what happens when you call 988? Well, when you call 988, you're going to hear an automated message while your call is being routed. So the call does get routed to the 988, to the crisis line that is local to that individual. So recently I found out that they are actually using the person's area code. So we all know that some people do have cell phones out of the area code of where they live. So I believe that the national line is trying to fix that right now. So it's more focused on where that person is located as opposed to their phone number. So you will be routed to a local crisis center. And the reason that an individual is routed to the local crisis center is because that individual is going to know the local resources. So you don't want to be on the phone with someone that lives in Alaska when you live in, DC, because they're not going to know what your resources are going to be where you are located. So the individual will be put on the line with a trained crisis worker at that local center. So that person is trained on how to assess a person's suicide risk, as well as knowing what those resources are that we just talked about. And then that individual will listen, support, and then guide them to the appropriate help. If that individual feels that that person is at risk immediately, he or she will will call 911 themselves and send someone out immediately to make sure that that individual is safe. So in a crisis situation, we are at the end of this now. Thank you all for sitting through this. I know this is tough. So in a crisis situation, you do have three options. You can call 911 if it is an immediate emergency. If you are extremely concerned about someone's safety and you're worried that they might hurt themselves right then and there, you can call 911. Law enforcement does know how to evaluate someone for their level of risk. So you can have them come out because they are more trained in that than you are. The other thing you could do is call 988, as we just went over. And then finally, most areas do have mobile response teams. Again, I know you are all spread all over, so I don't know what they might be in your area. But if you are interested, please make sure that you Google it and find out who that might be. And you can call them as well. So what is a mobile response team? That is a team of trained professionals. Usually they are licensed people who will come to that person and evaluate them. So those are the options. If you do have a situation where you are concerned about someone, you can do what's called a wellness check. And what a wellness, that might be, let's just say, and I'm giving an example, let's just say you were talking to someone at work and later on you started to think about some of the things that they said and you thought, you know what, I'm concerned about them. So you then try to reach out to them and you cannot reach them. And so maybe you reach out to a family member and can't reach them and you're worried. You can then call the non-emergency line for the local police and ask them to do a wellness check. And all wellness check is they go to the home, they knock on the door, and they check on the individual to make sure that they're okay. And we use that a lot. So please make sure that you're aware that you can do that as well. We are at the end. I do want to give you a chance for questions, and I also want to kind of lighten this up a little bit and say, fortunately, you're not going to be in these situations a lot, but your organization did want you to have some training on it. So we did want to provide that for you. I'm sure that you have resources, as you see in that list that you were provided for your EAP. That those are the professionals, so never feel like it is your responsibility. Just guide that person to the right resources. Again, you are not professionals in mental health and you're not expected to know all of this. Just know that if a person does complete suicide, it is not your fault. And again, it is never one thing or never anything you said or did not say. Again, I want to remind you all to please pay attention to your own mental health needs and your own self-care. And, we all could use a little support, right? Everybody can. Even the best of us have times that feel really stressful. So I encourage you not to be afraid to reach out if you need that. And at that note, I'm going to open it up to anybody who might have some questions. Thank you all for being so patient.
I am going to turn the recording off right now. So for any of the questions, they will not be on the recording. If anyone has things to answer, let me click that off. That way all the great information can kind of marinate in your